So let's move on to talking about some new return to run criteria after shin splints. Now, bone stress injuries are very, very common among runners, and they have a very, very high recurrence rate. So understanding shin splints, understanding tibial bone stress injuries is really, really important, and making sure that you have an evidence-based return to run and to assess the criteria to initiate a return to run is really important. So some of the criteria to be able to make return to run decisions, what we're looking for is to be able to assess symptom reproduction with things like palpation, walking, and functional tests. And lastly, with return to run programs, we want to first focus on increasing running duration, followed by intensity or speed, and then lastly, frequency. I'll give you a step-by-step process of exactly how to do that. So as I mentioned, these injuries are very common. Tibial bone stress injuries are going to be 20% of runners, and unfortunately, they have some of the highest recurrence rates of all running injuries. So clinicians obviously need evidence-based return to run criteria, and we also need really good return to run programs to make sure these patients aren't getting hurt and are recovering appropriately. Now, while diagnostic criteria has been really well established, and you are welcome to check out running resources for that as well, until recently we didn't have a guide to be able to understand when it's safe to return patients to running. So here is the criteria that you should follow. So after tibial bone stress injuries, we would want to look for a resolution of local bony tenderness at the posterior medial tibial border. Now I'm specifically talking about the posterior medial tibial border because that is the area where most of these shin splints occur. However, I do want to take a moment to say there's different areas of shin splints, there's different areas of bone stress injuries, and it is important to identify which bone stress injury you are treating. So that may change your treatment and your plan of care. Another thing you want to evaluate your patient for is that they can pain-free walk for 30 minutes with 5 consecutive days of pain-free ADLs, or activities of daily living. Also, imaging can confirm bone unionization, but we only use this for high-risk injuries like the anterior cortex of the tibia and a couple other injuries that are related to bone stress injuries. So what do we use? We also are going to use strength and functional test scores. We want them to be 90 to 95% on the limb symmetry index. And then also we want to address contributing factors like running biomechanics, footwear, even menstrual health, nutritional deficiencies, and energy availability. Now, clinicians should be aware that this imaging, as I mentioned before, is only necessary for high-risk bone stress injuries. That would be like your anterior tibial cortex, as we mentioned before. Some of those might require surgical fixation, so there's an important thing to differentiate. The other thing is we want to definitely take an amount of strength the patient has, and that can be done by isometric muscle testing via manual muscle tests and dyometry. However, the real valuable information is going to be functional testing. That's going to be more reliable, and it's going to really help you make return to run decisions. Now, clinicians should calculate the limb symmetry index for each of those objective tests, and over 90% on the limb symmetry index is really required to initiate a return to run program. So which functional tests do you want to do? Hop tests are going to be most applicable for tibial bone stress injuries, and particularly useful are going to be the crossover hop test, side hop test, and triple hop test. Now, there's full explanations of each of these functional tests in runner resources. However, take a special look at different tests that you can do. There's different tests that are going to be appropriate for different injuries, and you want to be careful, especially with shin splints, that you're doing a test that is relevant. Potentially a single leg squat, or potentially a single leg stance isn't enough of a high level functional test to be able to be appropriate for tibial bone stress injuries. So clinicians should also address these contributing factors to tibial bone stress injuries, such as running biomechanics and footwear. Now, running shoes is a big topic, and I'll quickly make a note here that running shoes with a moderate amount of cushion, moderate amount of control have been shown to produce the least amount of impact through the tibia. Really be careful when you're prescribing running shoes that are minimal or max cushion, because those are directly related to higher impact forces. We want to be careful also when we're prescribing and recommending shoe medial arch support. The arch support is important, but be careful because too much arch support could put too much pressure through the tibia, because we do know that excessive navicular drop has high correlations to tibial bone stress injuries and shin splints. However, the appropriate size is really important. We want to definitely recommend the right shoes. Oftentimes, changing running shoes can be a very complex topic, and a lot of runners have an attachment to their shoes. Check out the running shoe reference guide as part of running resources, and that will definitely help you get good shoes for your patients. Now, when initiating a return to run program, clinicians should also consider gait retraining as well, and that can help change some of these biomechanical issues with their running style. However, as we know, they can only be so effective with gait retraining before we talk about strengthening and appropriately grading return to run. But cues like run softly, run quietly, run with shorter steps have all got good evidence that they reduce impact while running and are going to reduce the tibial load. Now, to monitor running in real time, you can also use wearables. Initial measurement units are quite effective to monitor high impact forces and overstriding, so it is something you can use. Check out our article and our report on wearable technology and specifically how to monitor impact forces with inertial measurement units. Now, patients returning to running after tibial bone stress injuries will definitely benefit from a gradual return to running. Now, we want to be very careful here. Bone stress injuries are notorious for recurrence rates and are susceptible to impact. So we want to make sure clinicians can monitor runner pain levels quite frequently. We also want to empower runners to be able to make decisions and return to run decisions effectively. So first, you should focus on increasing running duration, followed by intensity or speed, and then frequency. And as we can see here in this chart, there's a couple different phases. So in our first phase of return to run, we would want the runner to run at 50% of their normal pace every other day for 2 weeks. And we're going to slowly add time to their runs. Then we want to give them more running distance, and we're going to increase the frequency as well. So as we give them more running distance, we can see that this is going to also move towards increasing their pace. So once they're at their normal distance, pace is gradually increased, and then finally we're going to slowly increase the frequency to their runs to pre-injury levels. Now, one important thing to note here is if the runner has symptoms of pain, they are instructed to stop running for 1 to 2 days and then resume running at the last pain-free phase. As you can see in this chart, in this graph here, you can definitely see stage 1, 2, and 3, and you can see that they're broken down into walking phases and running phases. We're adding more and more duration first, then we're going to increase the pace, and then lastly, we're going to increase the frequency. If you have any questions on this running specialist report, feel free to reach out, and until next time, happy running.